Ramesh, you're on mute. I think we can start now. You're on mute.
Yes, sir. We'll start our thing.
Go to presentation mode.
Good evening, everyone, and I'm starting the overall meeting proceedings in this regard. I extend a very warm welcome on this special day on World Hepatitis Day for the panel discussion primarily on the topic nutrition across the liver disease journey from cirrhosis to successful liver transplantation. A complete broad area is being covered primarily, and we have three experts primarily who will be driving this particular session. Before we move to the introduction of the speakers, I'd like to briefly talk about what Pulse do. Pulse NutriScience is an innovative nutraceutical company specializing in science-backed disease-specific nutritional formulas in clinical nutrition, wellness, as well as in weight management. The company operates a state-of-art manufacturing facility at Hyderabad with a monthly capacity of almost 75 tons of spray-dried powders, along with 150 tons of dry blend powders. So we have a huge manufacturing facility, and we are one of the few operators who provide the spray-dried technology, which provides the product consistency as well as the deliverables to the patients. With a growing presence of Pulse across Africa and Asia Pacific, Pulse is expanding into Eurasia, CIS, MENA, and Latin markets through strategic global partnership. Not only in India and across the other regions, what I've specified, we have been significantly present in this regard. With this brief introduction of Pulse, let me now move on to the introduction of the speakers. I have a great pleasure in inviting Dr. Munish Karunagaran, the DNB and General Surgeon, DNB in Surgical Gastroenterology, MRCS ED, Consultant Surgical Gastroenterologist, HPB Surgery and Liver Transplantation from ICRA International Hospital and Research Center, Kozhikode, that is Calicut in India. He is also a senior lecturer academic and MD Advanced Studies, Flinders University, Adelaide in Australia. He is a member Research Committee Asia Pacific, HPB. So thanks a lot, Dr. Munish, for taking your time out and giving us, being available for this particular panel discussion in this regard. Next panelist, I move on to Ms. Reshma Ali, Head of the Department of Nutrition and Dietetics at Dr. Rela Institute of Medical Center, Chennai. She is specialized in both adult and pediatric transplants. She is also a former clinical dietitian lead at Rainbow Children Hospital, Chennai. She is also former clinical dietitian from Apollo Hospitals, Maine and Apollo Children Hospital, Chennai. Comes with a very vast experience. LEC member in Chennai chapter and Indian Dietetic Association, registered dietitian, certified diabetes educator. Thanks, Dr. Ms. Reshma, for really taking a lot of effort in terms of putting all the presentations together for this particular webinar, and look forward to hear from you from there on. And I also introduce the next panelist as well as our moderator for this evening, Dr. Radhika Venugopal, a senior consultant hepatologist and liver transplant physician. Dr. Renuka Venugopal is an assistant professor of hepatology, Madras Medical College in Chennai, consultant hepatologist, Government Stanley Medical College Hospital, former fellow in transplant hepatology in Dr. Rela Institute and Medical Center, DM hepatology gold medalist. Congratulations, ma'am. National and international, she is also a national and international faculty. an expert in liver transplantation, cirrhosis, MASLD, and viral hepatitis. It's a great delight to have three experts here with us to discuss on the topic, primarily on from cirrhosis to successful liver transplantation. May I hand over the session to Dr. Radhika Venugopal, ma'am, to take the proceedings forward from here on. Thank you.
Thank you, Mr. Ramesh, and good evening, everyone. And thanks, Pulse NutriScience, for inviting me to be a part of this wonderful expert forum on this World Hepatitis Day on nutrition across the liver disease journey from cirrhosis to successful liver transplantation. I think if you can stop sharing.
Yeah, I stopped sharing.
I think the screen is visible to everybody now.
Yes, ma'am. It's
Okay.
visible now.
So, nutrition in cirrhosis sounds deceptively simple. We tell patients to eat enough calories, take enough protein, and restrict salt and water. But in clinical practice, it is very complicated because most of the time they are hospitalized and they have hepatic encephalopathy, ascites, tapping, upper GI bleed, or ICU admissions for sepsis. On these instances, their nutrition goes down very badly. And then we expect these same patients to withstand one of the largest operations in medicine, that is liver transplantation. So rather than discussing nutrition as a series of recommendations, today I would like us to follow one patient through his transplant journey. So here is Mr. R. He is 56 years old. He has been diagnosed to have a MASH-related cirrhosis, and he has been on workup for liver transplantation for refractory ascites requiring repeated ascitic tapping and 2 or 3 episodes of hepatic encephalopathy. And his MELD score is MELD sodium score of 21. And he is on examination. He looks thin. His arms and thighs have become more thinner, and his wife confirms the same. And she also says that he's physically looking good, but he struggles to get out of the chair and cannot climb a flight of stairs. And his appetite is also very low, and he eats only few mouthfuls. On examination, his current weight is 82 kilograms against a height of 170 centimeters, and his BMI is of 28.4 kilogram per meter square. So first I would like to ask Reshma, if I send this gentleman to you for an assessment, simply write nutritional assessment before liver transplantation. Where would you like to start? Because the patient looks healthy, because he has a very good BMI, which reflects a good nutritional status. What is your opinion?
Thank you, ma'am, for the question. So, patient has come to us with ascites, and that is refractory ascites. So several times this accumulation has been there. So first, I would like to ask him about his original weight, what he was there 2 years before, so I can track his weight history over there. So when I know probably his original weight, for example, he would have been 90 kgs before, and in a 2 years time with ascites, he has become with 80 kgs. So obviously he would have muscle wasting, his MUAC will be less, his TSF would be less, and his wife also tells that he's not able to walk. So that also shows that he is sarcopenic. So simple, he's not able to walk enough itself shows that he has a lesser muscle strength. So here we commonly use what is called the Royal Free Hospital prioritizing tool for patients when we do liver transplants. So it is a very easy tool because it says alcoholic hepatitis or a tube feed patient, whether they are having weight loss, whether their BMI is appropriate, whether their intake is very less, or is the ascites or is the ascites hindering the intake of their food. So all these parameters we look into them and then take the dietary call also. But when we do this, we also have the physiotherapy doing the other things such as the hand grip, liver frailty index, and also the SPB score also for these patients. So with that, we come to a conclusion. Whichever tool we use, whether even it's a global assessment, subjective global assessment, or even a simple tool such as the GLIM tool, which captures the phenotype and the etiological criteria, whichever tool you assess, it should be easy enough to come to a conclusion that the patient is malnourished for you. So here, even his dietary intake is captured. We calculate what is the requirement for him minus what he is taking and what is the deficit he is in. So whether in this deficit he is able to cope up with the deficit, then he would go on an oral diet. Otherwise, no, he would go for a nocturnal feed or a tube feed, depending upon what his dietary intake has been there.
Thank you.
So here, even you said, yes, ma'am.
Sorry to interrupt you. Actually, I want you to emphasize on something called as dry body weight and how do we
Yeah,
arrive when there is
yeah.
high
So
BMI with a
yes,
refractory.
yeah. So the dry body weight here, we take it for mild, moderate, and severe ascites. We minus 2, 6, and 14 kgs. Plus, we also add on edema. If it is mild edema, 1. If it is moderate is edema, again we minus 5 kgs and then 10 kgs. So then we arrive to what is called as the dry body weight.
Okay. Thank you. So the perhaps one of the first messages tonight is that a cirrhotic patient can be overweight on the weighing scale and undernourished at the level of skeletal muscle. So this is the first take-home point from this patient as of now. And the recent guidelines also specifically warn that fluid overload can confound BMI and recognizes malnutrition with obesity and which is called as sarcopenic obesity. So thank you, Reshma, for clearly explaining how do we approach a patient with high BMI with refractory ascites, fluid overload, and how to calculate the dry body weight, with which only next we are going to nutritionally rehabilitate him. So next, as you saw that his albumin was 2.5 grams per deciliter. Would any of you use this albumin of 2.5 gram to diagnose malnutrition? Dr. Monish, do you want to answer?
Yeah, I mean, I would not use albumin as a marker of malnourishment in this patient, in any, for that matter, in any chronic liver disease patient, because in CLD patients, hypoalbuminemia is more of a reflection of decreased hepatic synthesis. And it is, I mean, we all know that cirrhosis is a inflammatory state. So this is again a negative acute phase reactant. And of course, cirrhosis has been associated with fluid in the body more than what it is. So there could be always a dilutional component to the hypoalbuminemia as well. So purely from a nourishment, malnutrition perspective, no, albumin cannot be used.
So if I give him albumin infusions regularly and his albumin is around 3.54 or above 3, so do you consider that this nutritional status as an improved state, or still we say that this does not reflect his nutritional status?
I mean, it does not, obviously, not in a chronic liver disease patient, and not even in a regular patient without chronic liver disease. Albumin improvement by just giving albumin doesn't equate to nutritional improvement. Yeah,
Thank you, Dr. Monish. So this is an important point. It's another important take-home point is that albumin infusions, the albumin per se is not a reliable nutritional biomarker in any patient, and in especially in cirrhotic patient for all the reasons listed out by Dr. Monish. Because albumin infusion has been as established therapeutic indication in cirrhosis, but it is not a nutritional replacement. Correcting the laboratory albumin is not equivalent to rebuilding skeletal muscle. This is the next important take-home point which I want to emphasize. So these are all the pathophysiologies as discussed by Dr. Monish. So coming back to his physical assessment, from a surgeon's perspective, how worried are you about the statement that he cannot rise easily from a chair? Would that influence how you view his transplant risk?
It's quite alarming. Not, I wasn't very happy about it. So basically, I believe that inability to perform activities of daily living is one of the most important red flags in any patient planned for a major surgery, including a liver transplant. From the history and the clinical picture that you give me, I infer that the patient is frayed, by which I mean to say that he has reduced physiological reserve and diminished resilience, which in turn leads to increased vulnerability to normal physiological stresses. And this patient is at a very heightened risk of adverse events such as infections, decompensation, hospitalization, and even mortality. So it's a very poor prognostic sign, inability to get up from his chair.
Yeah, that is what actually what you say, the reduced physiological reserve, what we call frailty, is an important marker which says that there is high peri-transplant risk. So when we use the words malnutrition, sarcopenia, and frailty almost interchangeably, do you think they are all same or they do infer separate entities?
I mean,
What do you think, Dr. Mukesh?
to put it most prudently, I would say that malnourishment, malnutrition, sarcopenia, and frailty are all very distinct constructs. But yes, they do have quite a lot of overlapping features. For example, when I say malnutrition, I generally refer to the nutrition, the nourishment part of it. When I say sarcopenia, I refer to the muscle mass as well as muscle function. And we have already talked about frailty. Frailty is increased vulnerability to stressors. So they cannot be changed. They cannot be used interchangeably, though they have a lot of overlapping features.
Yes. So all these three words mean separate entities. That is, malnutrition is, as he said, it is nutritional imbalance. Sarcopenia is loss of muscle mass. Not only muscle mass, there is loss of muscle strength. And as earlier said, frailty means there is impaired physiological functional reserve. And these are all not separate entities, though they define separate features, they are all interlinked. And we need to address each and every point so that the patient becomes more better before transplant. So, if we have to introduce a simple sarcopenia frailty protocol in every transplant clinic, what are the things we should measure? Dr. Monish, you
Very,
can answer.
yeah, very good question. I've always been a big fan of this concept of frailty. So I would recount what we used to do 6 years back. 6 years back, we did frailty assessment on all patients who were being planned for liver transplant. So we found that we used to use LFI, the liver frailty index that has been floated by Jennifer Lai. It is very simple to administer. It takes hardly 3 to 5 minutes in the clinic to do it. It basically involves hand grip strength. Basically, we take a average of three attempts. Then the chair stands. Chair stands is nothing but time taken to do 5 chair stands, and we ask the patient to do as fast as possible. And balance. Balance is done in 3 positions: feet together, side by side, tandem, and semi-tandem. So all this data is then fed into a calculator, which will give you the score. So score of less than 3.2, we would call the patient robust. Between 3.2 to 4.4, it would be pre-frail, and above that, it would be a frail patient. Now, this is frailty. Then we, along with it, we added the skeletal muscle data in terms of L3-SMI. So these LFI as well as SMI was then added to the MELT score. We found that there was an incremental increase in our predictive power when MELT plus LFI was used, and there was, which further improved when SMI was combined with it. So basically, all the three are useful, very useful, and I believe the best prediction we would get when we combine all three. So probably MELT 4.0 would involve SMI. LFI without SMI.
So, thank you, Dr. Monish, for clearly explaining what frailty means and how easily we can measure liver frailty in anybody's office. Does not need a big transplant center or bigger setup to measure frailty in any sarcopenic patient or any cirrhosis patient who, whether they go for a transplant or not a transplant candidate, or it has been managed in a non-transplant centers. Measuring liver frailty and addressing the nutritional needs is a very important point. Thanks for emphasizing that. And that was a very phenomenal work on the sarcopenia along with the MELD score. But I would like to ask you one question that we see not all patients, not all centers. If it is not a liver transplant center and the patient has been managed by some gastroenterologist in a tier 1, tier 2, tier 3 cities where right and left we can't take CT scans. Any other means of measuring the muscle mass? Anything else you want to add to those people who doesn't have an access to right and left CT scans like what we do in our transplant centers?
Yeah, good question. But the problem with using bioimpedance is that it's not very good for a patient with cirrhosis because it's got too much of fluid which interferes with the readings. Then DEXA, I'm not sure how much of it, I mean, it is good. See, my point in emphasizing on CT scan is most of the patients will get a CT scan.
Yes, yes.
May not in a longitudinal basis, but they would have had a scan. It's an upcoming thing called muscle sound or muscle ultrasound. But again, I think availability is an issue. I don't think the smaller center, I mean, it has gone beyond the biggest or the big centers.
Any experience of using any ultrasound guided rectus femoris muscle strength? These are all studies being done
Yes.
left and right on sarcopenia and frailty.
I believe most of that is operator dependent, whereas CT is quite objective and reproducible. And I believe, I mean, even in non-cirrhotic patients, I felt CT was better than the bioimpedance.
Yes, yes, definitely. Because we see the muscle, we measure, there is a software. Even if there is no software, we can measure and get a thickness and get the psoas muscle area. So that's one of the important point here. So now we move on with the next patient. This is what Dr. Monish has explained in detail, how we go about assessing the malnutrition, frailty, and sarcopenia in a patient who's been worked up for a liver transplantation. So these are all the diagnostic toolboxes. What are the questions we are asking? What are the performance scales, physical examination findings, and objective measures? The main important point is frailty, sarcopenia, and malnutrition is not a subjective assessment. We need to go for objective tools to categorize the patient as having a frailty. As Sir said, the categories 3.2 and 3.2 to 4.4 and more than 4. So, to Reshma, so if we see, we have assessed, Dr. Monish has seen this patient and assessed this patient, and he's frail. He's more than 4.5. So, before we prescribe nutrition, what are the steps? What do you do to understand how to prescribe a specific nutrition for this patient? Because we can't give the same nutrition for every patient. What do you do?
Yes, ma'am. So while assessing his dietary intake, his cultural beliefs are also there. From which area of India or which part of the world they are coming from. So they have different beliefs. And when it is liver disease, the family itself has a lot of fallacies, and they already have changed diets, and they already have brought the patient with weight loss with those diets. So when we are taking recall, as I said, the deficit only I have to take into account. But whether he's able to take what I'm prescribing, might be for his ideal body weight 70, I can calculate 2100, 2500, protein, I can calculate 90 to 100 grams. But how is this going to be practical in his scenario is very important. Whether sometimes he may get an upset for the oral nutrition supplements, he would not like the taste of the supplements, food is not palatable because of the salt intake which is there. So we can add some of the flavors of food or herbs which can improve his intake over there, and which trial of supplement which he would like, which for the taste we can try, or he doesn't want to drink it as a supplement, we can just mix it with the food for him, so that, and see whether his favorite foods, at least the quantity of the food is important for us. So whether he's able to take that quantity is very important. So if he's not going to take that quantity, then I would want him to see him again in the OPD in the following week till transplant, because you have said this patient is sarcopenic. So if he has to come back to me again in another week's time, whether what I have prescribed he is taken, or what is the next step I can take for him, whether if oral is not sufficient, then it is enteral for him.
Okay. So as Ms. Reshma said, the 24 hours dietary recall will be the first step in nutritional rehabilitation for any patient. And as per that, we have done a 24 hours recall method for our patient R. So he is taking around 1400 to 1500 kilocalories per day and 45 grams per day. So, and they used to stop proteins during the episodes of hepatic encephalopathy. And since he has a refractory ascites, there is no added salt in his diet. What do you think about this, Reshma? And before discussing the supplements, how are you going to achieve what, based on what guidelines are you going to prescribe the calorie and protein prescription to him?
Ma'am, because you said ascites, so if you're going to minus the ascites, I'm going to get his actual body weight over there. So my calorie and protein will be for here. He has not been taking any salt. At least a little salt for his lunch dinner could be added on to the quantity of food he's taking, which would make the food more palatable over there. And here, because of HE, they have avoided all the protein supplements and non-veg.
I think, Reshma, your voice is getting broken. Can anybody else hear her clearly?
Sources also have been avoided. So as HE, all the actions which have been,
I think we
So
got
from
it,
my
ma'am.
side,
Voice is coming correctly. Go ahead.
Yeah.
okay. So I would focus on the protein sources which he liked to take, and along with the supplement. If the protein sources are not matching the protein, I would give the supplements after food and make will be so that he will be meeting the protein requirement throughout the day. And also a bedtime supplement or a nocturnal supplement, so that we can reduce his fasting time, his accelerated starvation there, so that he doesn't get more malnourished.
So thank you, Reshma, for explaining in detail how you go about adjusting his calorie requirements and protein. So I would add on to this. So what do you think is a bigger problem for this gentleman? Finding an exotic nutritional supplement or simply closing this 50 to 60 grams daily protein deficit? So how are you going to do this? This extra protein?
So finding a supplement which is matching his taste would be trying all for me would be better for him, ma'am, because he will not stick to one thing. If he doesn't like, then he is not going to follow that or stop that supplement, come back to me and say that I have not taken the supplement at all. So it is very important. I will also explain him that if he's not taking supplement in the food, he has to replace this much amount of protein.
Okay, thank you, Reshma. So what happens? See, you have done so much work. Dr. Monish has worked up this patient, identified that he's sarcopenic, malnourished, and he's severely frail, and he's going towards a liver transplantation. You have extensively evaluated his 24 hours dietary pattern, found out the right supplements, and gave a extensive counseling regarding the calorie requirement. So, what do you see in practical? We prescribe 2000 calories. The diet sheet also adds up to 2000 calories. But does the patient actually receive the 2000 calories? And what do you think are the biggest barriers in real life? Both Dr. Monish and Reshma can answer this question. What are the nutritional perspective and what are the clinical perspective which makes the cirrhotics not to eat?
Here, I would like to start off with a very difficult phenomenon that we find in nutrition, which is not so common in our pharmaceutical prescriptions. Like the guideline compliance never reaches the prescription compliance.
Very true.
And further down the line, the bedside compliance is only a part of the prescription compliance. So yes, which says that there are a lot of barriers to following what should be followed in real world. So the most common things that one encounters in a chronic liver disease patient is they're anorexic, they have dysgeusia or altered taste sensation. People would have restricted his salt intake, which would make his food completely bland and unpalatable. Plus, and as in this case, these ascites can lead to early satiety, low intake, and very importantly, there could be socio-economic barriers. Economic barriers, particularly because we live in a third world country. Many people don't have an access to high quality protein, especially the animal protein. Then on top of it, there are persistent misconceptions like protein restriction. So I would sum up saying that they are multifold, and it requires a lot of effort from our side to obviate these issues.
Yeah, sure. So, as rightly said by Dr. Manish, that these are all the points will stop us from achieving the adequate calories. And in those situations, as Ms. Reshma has already said, that we can bridge the gap with ONS and nutritional supplementation through nasogastric tube feeding, where we give little amount of high caloric food continuously and nocturnal feeding also. Reshma, do you want to explain more about this nocturnal feeding and how it is going to help us, our patients with refractory ascites?
Ma'am, if the patient intake is less than 50%, then I would not go in for a nocturnal feeding. I would go on a continuous 24-hour feeding or a 16-hour feeding. Because as you said, he has discomfort, he has a big refractory. So
Mr. Reshma, your voice is breaking.
And I'm very, very less time before the transfer for me to rehab the patient through NG feeds.
Good, thank you. So NG feeds forms mainstay for these patients who are willing to eat, but they are not able to eat because of refractory ascites and early satiety, and less palatable food because of sodium restriction due to refractory ascites and low sodium. That is dilution.
A small question. So do you keep the patient hospitalized for a specific period before transplant? Like, how long do you do it? Like NG feeds, I'm sure not many people are comfortable at home, especially before transplant.
So we do send people home with NG feeds, sir.
Yes, sir. They stay NG feeds.
Yeah, we do send people on home for NG feeds, continuous NG feeds also, and then with specific nocturnal feeds also. They take care of educating the people, and we do send home. We have had people on NG feeds for months together. There was 2 or 3 patients who are waiting on DDLT listing with refractory ascites who come with tapping every week. So those people were on nasogastric feed on top of the oral feeds for months together. We are comfortable.
Lack of a suitable organ makes it logistically possible in liver transplant to do that.
Yes.
Yeah.
Exactly. Okay, so when we move on to this patient, so these are all the reasons listed out by Reshma and Dr. Monish. So now again, this patient now develops recurrent hepatic encephalopathy. And again, in spite of counseling, his family immediately stops his protein supplement. So, doctor, whenever he becomes confused, we stop protein. And wow, would you ever ask for protein restriction in hepatic encephalopathy? Any of you can tell. And if not, what is the basis? Why not protein restriction? Because that is the basis for ammonia production.
Again, dogma runs deeper than data. So this is again one of the biggest myths in chronic liver disease that HE calls for a protein restriction. In fact, what is true is the contrary. The protein restriction should not be advised in patients as it causes more harm. So what we need to understand is that the urea cycle in the liver, which is basically responsible for converting the ammonia into excretion of ammonia, decreases in these patients with liver disease. Now, the entire responsibility of flushing out the ammonia falls on the muscle. So, by decreasing the protein intake, we're actually making the muscle weaker in structure as well as function. The skeletal muscle, with the help of glutamate, can convert the ammonia into glutamine and helping in its excretion. When this doesn't happen, there is actually worsening of sarcopenia, which in turn leads to a worsening of the hepatic encephalopathy. So that's the reason why we should not restrict protein.
Yes, yes, Dr. Monish, as you rightly pointed out, that protein should not be restricted because We remove the part of the organ that helps us handle ammonia, that is the skeletal muscle. We are trying to build it back because of his sarcopenia and frailty. And during these episodes, if we stop protein, again it goes into catabolism and then it worsens and precipitates other cycles of hepatic encephalopathy in worsening sarcopenia cycle. So protein should not be restricted even during hepatic encephalopathy episodes. So if he had grade 3 hepatic encephalopathy, should we continue his oral nutritional supplementation?
As long as the airway and yeah, I mean, since I thought it was a yeah.
It was a question for you only, sir. Because you answered most of the same thing. I wanted Reshma to add on anything from her side. So first you say and then let her add on any points from her side.
As long as the airway and swallowing is okay, it's always good to go with oral feeds. But there is definitely a problem in grade 3 and grade 4 encephalopathy where the patient is at higher risk for aspiration. In that case, we can always put an NG tube and start the feeding. One common issue that people might raise is it safe to put in when the patient has got esophageal varices? So most of the guidelines do recommend it is safe to put in. So
Yes, sir. So we do have the small lumen Frica tubes. So those are supposed to be very safe even if they have esophageal varices. And we do continue nutritional or ONS or NG feeds in grade 1, grade 2. But in grade 3, grade 4, we don't actually give NG feeds because anytime they can go in for respiratory distress and they can go for an intubation and mechanical ventilation. So our ICU people does not usually want the stomach to be full. So we keep only clear liquids in these patients. And these people Reshma, how do you manage these grade 3, grade 4 hepatic encephalopathy patients whom the ICU people does not want to be on continuous NG feeds? How do we achieve the nutrition for these patients?
Ma'am, for clear liquids, that is only for some period of time. So as soon as this ammonia and anti-HHs are done, we start the NG feeds.
Yes. I have seen in few ICUs where the patient on
Next.
grade 3, grade 4 encephalopathies are kept without feed for 2 to 3 days. Again, that equals caloric and protein restriction.
Immediately
So,
itself. As you know, hyperammonemia block, this is only for just a small period of time.
Yes, yes. What you say is right. So we need to jump back to full nutrition as early as possible as he comes out of hepatic encephalopathy. So what is the role of other micronutrient supplementation, especially the role of zinc in hepatic encephalopathy? And does zinc have any other implications in managing a cirrhotic patient with sarcopenia?
Zinc is not routinely recommended, but in patients who have got a documented zinc deficiency, the guidelines do say that zinc should be given. This is because zinc helps in the same pathway, that ammonia to glutamine through glutamine synthase. This pathway is catalyzed by zinc is one of the cofactors. So since the ammonium excretion is entirely dependent upon this extrahepatic pathway, zinc supplementation helps in patients who have got a documented deficiency, but routinely it has not been shown to improve outcomes.
Okay, sir. Thank you. So, routine zinc supplementation and a replacement is not, it is an additive. So, it is actually an additive which can be given for patients with hepatic encephalopathy. It cannot replace any other anti-hepatic encephalopathy measures. Okay. So, where do these branch chain amino acids actually fit in managing this patients with sarcopenia, recurrent hepatic encephalopathy, and refractory ascites?
Yeah, the moment a junior doctor or a non-hepatology person sees CLD patient, the first thing he writes is probably a branch chain amino acid supplement.
Yes.
But it is not very data based. It should not be routinely given. It should be given only in those patients who have got an inability to meet their daily protein requirements.
Yes.
Who have got regular protein intolerance, patients with recurrent HE, because these branched chain amino acids are a source of glutamate, which can help in conversion of ammonia to glutamine, and in patients with frailty and sarcopenia. But again, in frail and sarcopenic patient, branched chain amino acid supplementation has not been shown to improve the actual outcomes in terms of perioperative outcomes. So, yeah.
So yes, truly the BCCA should not be prescribed as the first before meeting the adequate protein and calorie requirements. If the protein and calorie requirements are good and they are able to achieve with diet, there is no need for BCA's supplementation. But when the patient struggles to meet the protein requirement and is not able to tolerate other proteins, yes, definitely BCAs can be supplemented. So, any pointers towards the late evening snack? Why hepatologists are so obsessed? Every hepatologist would finish their consultation with salt restriction, fluid restriction, and late evening bedtime snack. Surely one snack cannot change sarcopenia, but why we emphasize on that late night snack? Any physiological, pathological implications for that?
Yes, Pam, because when it is overnight fasting of 12 hours for a cirrhotic patients, that is equivalent to a normal fasting for for a 3 day duration. So that is the rate of accelerated starvation. So that's why, to cut off that accelerated starvation, so after they finish their dinner, we tell them when they go to bedtime, whether it's 10:30 or 11 o'clock, that's the last thing which they should have. And that snack should at least be more than 200 calories and 10 to 20 grams of protein at least. That is only a nocturnal supplement or a bedtime snack which can cut off the accelerated starvation. And sometimes, if possible, we tend them to have an early breakfast. Otherwise, even if they are having a late dinner for them, we are very, very happy for that.
Okay, sure. As rightly said by Reshma, cirrhosis reduced glycogen reserves, and there is an earlier shift towards fat oxidation and gluconeogenesis during fasting. This is called as accelerated fasting in the cirrhotic patients. So we need to shorten the fasting periods, and the recent ASLD guidelines also says that there should be small frequent meals and not more than approximately 3 to 4 hours between nutritional intake while awake, and plus an early breakfast and or a late night snack. So, Reshma, would you want to add something like what an Indian patient, like a South Indian patient or an Indian patient, to eat as a late night snack? Many of the patient ask us, what could be an ideal late night snack?
Ma'am, late night snack, we usually don't give them any food, because any food doesn't come around that 200 or 250 calories and 20 grams of protein at one shot. So we tell them to go for supplement only, which can give them that 250 calories and 20 grams of protein. So food will be heavy to meet up that 250 and 20. So we would ask them to take a dinner full, whatever they like, and then keep that supplement for a late night snack.
Very good. So it's so simple or easy to use a ONS in the night. That will be a better alternative in the night rather than asking them to prepare a snack and eat. So the takeaway point from these last few discussion is that nutritional prescription in cirrhosis is not merely what we eat. Meal timing is also matters. Okay. So we return to Mr. R. So his ascites remains refractory. So his wife has made his diet salt free. Everything tastes terrible. I don't feel like eating. So what is most dangerous now, the sodium or the starvation? And is there a way for liberalization of salt in patients with refractory ascites, especially patient with refractory ascites?
You don't need to be too harsh with, or I mean, rather too strict with the salt restriction, because the salt restriction should not restrict the patient from eating at all. It's easy to cut down sugar, but cutting out salt literally makes food almost unpalatable. So if ascites is there, we should, think of addressing it with pharmacological means and repeated large volume paracentesis rather than, risking starvation by limiting the sodium. Because here the problem is probably not increased sodium intake, rather, the excretion is low. So the I mean, people have started advising not very strict salt restriction.
Okay, so ideally, yes, as Dr. Monish said, we can, as per guidelines, we can liberalize salt. Anyhow, he has a refractory ascites, a number of salt restriction and fluid restriction is not stopping him from getting his regular ascitic tapping. So we can have a little bit liberalization in his salt. And mostly everybody takes home the message that it is not 2 grams per day. It is the 2 gram of sodium restriction per day. It is not the 2 gram of salt. It actually goes about to 1 teaspoon of salt, that is 5 gram per day. Many people go for 2 gram of salt. They measure and they take. So that itself restricts more salt intake. So we can be liberal with salt intake. So coming back to our patient, his hepatic encephalopathy improves, his calorie protein intake improves. The wife started following, giving an adequate sodium. He's also exercising well, and ascites is managed by dietary restriction and tapping everything. So now we have slowly improving this patient from frailty. So the question comes, can we actually reverse frailty? Can nutrition alone rebuild muscle if the patient remains sedentary? Most of our patients remain sedentary because they have breathlessness, they are hospitalized. So only nutritional rehabilitation can it reverse frailty, or do we need to add anything else?
So when we talk about optimization, I would like to use the word prehabilitation rather than rehabilitation.
Yes.
So any program, prehabilitation program, should be multimodal. There has been enough data across surgical specialties that multimodal programs work much better than the nutrition or single modality programs. So now we have talked in length and breadth about the nutrition in cirrhosis, but to get the maximum benefit in terms of both perioperative outcomes as well as survival outcomes, we need the synergistic help from a very important intervention called exercise intervention. So for any rehabilitation program, we need to have exercise as well. So broadly speaking, the data for exercise intervention in cirrhotics or patients awaiting, and patients awaiting liver transplantation is not very robust because there are practical difficulties in rehabilitating them. But any exercise program, taking the cue from other specialty programs, any exercise prescription should have at least 3 components. One should be an inspiratory muscle training, wherein we make the patient do spirometry training. Second one is endurance training, wherein we make the patient exercise on a cycle ergometer, or in our scenarios wherein most of the patients will not have a cycle, we can ask the patient to walk. If he's feeling comfortable while walking, then we can have him climb stairs. Third kind of intervention, which is the most difficult one to enforce, is resistance training. Right. So all these 3 combined act in a synergistic way so that the patients derive the maximum benefit. Again, let me go back to the number of modalities. Most of our exercise prescriptions or high energy, high protein dietary prescriptions will not work in a patient if he's anxious, he's depressed, which most of our patients are. So equally important are the psychological interventions like cognitive behavioral training, relaxation techniques. I'm not an expert at that. You almost always need a psychologist for. It's easy for us to understand and enforce nutrition or or a exercise thing, but it's, I mean, the psychology is completely a different ball game altogether. So you should always have a psychologist who can assess and advise the patient longitudinally, multiple at time points during the course of his illness treatment until, yeah, well beyond the discharge into the recovery. So I believe it should be multimodal.
Yeah, thank you, Dr. Monish, in explaining the bigger process in few simple words, the multimodal management, and specifically mentioning about the spirometry. That is one exercise which the people forget to do, because the intercostal muscle and diaphragmatic muscles also need to be exercised, and the lung function has to be kept better in a better stage before going for a transplant. So to
I had a very
summarize,
interesting point from a study wherein 4 weeks, I mean, we all think that strength training is difficult, but it improves the muscle function, but not the muscle mass. There is a study in which they did pre-intervention as well as post-intervention CT scans. They compared it. There was a distinct, significantly increased thickness in the diaphragm muscle after resistance training in patients. I mean, it is not from liver transplant cohort, it's from a pancreatic surgery cohort. So, strength training, yeah, it's difficult to do, but probably reaps the maximum benefit.
so as Dr. Monish said, prehabilitation is a part of transplant preparation. It is not an optional wellness program. So the therapeutic target should not be just simple muscle gain or weight gain. It should be a functional muscle. So it includes adequate nutritional calorie protein along with exercises, and specifically to mention all the relaxation exercises, etc. So, so this patient now is managed well, and the transplant call arrives. So after 8 weeks of optimization, a suitable liver becomes available. So does any of this actually change the outcomes? That we have spent 8 weeks asking him to eat protein, exercise, and have his bedtime snack. From your perspective at the operating table and ICU, has any of this actually made your job easier? I just ask a practical question to you. What does it mean if the patient gets rehabilitated, prehabilitated in this 8 weeks and coming to the transplant, and who has not been prehabilitated and coming to the transplant? What difference does it make to you?
So basically, one needs to understand that liver transplantation is a very major surgery. So any surgeon practicing at any center in the world cannot assure in most of the cases, we are probably operating the sickest of the sick patients. So we cannot assure anyone that the complications will not happen. However, a prehabilitated patient will have higher resilience to deal with the complication than a patient who has not been. So that's what we are increasing, the resilience of the patient by doing all of these things. So I believe there's no one intervention that would actually help the patient. It's always a combination of intervention delivered by a team that helps. We don't need one superhero cannot win the battle. We need a team of superheroes or superheroines to win the battle. So I believe that more or less sums up. It's a big surgery, so you need multiple interventions.
As rightly pointed out, there is an enormous difference between the outcome of the patient who has been prehabilitated and those who have not been prehabilitated before surgery, and the outcomes, sepsis rates, and everything are very worse in those people who go for transplant, even with very sarcopenic and frail patients.
There is a metric. I don't know how many transplant teams, transplant community has. I don't know. I've not read much about it in transplant literature. Something called failure to rescue. So failure to rescue is a metric wherein a patient who has a complication dies. So that we fail to rescue the patient. So here, no, the numerator is same, mortality the same. The difference between mortality is that here the denominator is different. So I believe that with these measures of prehabilitation, we might be able to improve our failure to rescue rates. We might not be able to prevent a complication, but we might be able to salvage a patient who unfortunately had to endure the complication. So yeah, it's probably future studies can look at this.
Sure, Dr. Monish. Thank you. I had this last question for both of them, but this question was very well answered by Dr. Monish when he was answering the previous thing. So there is not one single intervention to improve the patient chances of recovering. It is always a multi-modality of interventions needed for rehabilitation of this patient. So with this, I think we have taken up the journey of Mr. R from refractory ascites, recurrent hepatic encephalopathy with a frailty score of 4.5 to Dr. Monish stable for a transplant now. So with this, we will close this discussion, and I would like to give some few takeaway points. That the key message is that nutrition in cirrhosis is not an add-on; it is a part of disease-modifying care and transplant preparedness, which is called as rehabilitation. So we need to screen every patient with cirrhosis for malnutrition, sarcopenia, and frailty, especially the transplant candidates. We should not rely on BMI or albumin alone because ascites can mask weight loss. Albumin reflects liver function. And the muscle function should be assessed objectively. You should not see that the patient is skin and bones and say that he's sarcopenic. So we need to measure the sarcopenia objectively by using the frailty score, muscle thickness, and muscle function with hand grip strength. And we need to aim for adequate protein and never to restrict protein in their diet. And we should avoid prolonged fasting and encourage frequent meals with a late night snack or a late night meal. And we need to treat hepatic encephalopathy without starving the patient. BCCA is an adjunct and not a substitute for adequate oral protein intake, and sodium restriction especially should be it should be individualized, and we can relax sodium in certain conditions. And keep in mind that simply prescribing the calories is not enough, and because they are not same as the consumed calories, and they have to be frequently monitored, encouraged to eat well. If not, we need to go for ONS or NG feeds. And important point, as Dr. Monish stressed, is exercise and resistance training. So in cirrhosis, we should not just ask what is the MEL score, we should also ask how much muscle and physiological reserve does this patient have to face the next insult or the transplant itself. Thank you. Thank you, Dr. Monish, and thank you, Reshma, for the wonderful discussion and research-based answers. And over to the organizers. Thank you. Thank you again.
Thank you, ma'am. And we have traveled with Mr. R for almost 8 weeks along with the people. And it's a wonderful case and an excellent presentation. There are a few questions which has come in the chat box, madam. I think, would you like us to read it out for you, or you can?
I think I'll just go through it. Okay, the first question.
The protein requirement in
case of urea 150, creatinine 1.9, and not on AKI. Reshma, would you like to answer, or Dr. Monish? Any one of you?
No, we still go with our regular protein supplementation. I mean, not supplement with the regular protein requirement.
Reshma, do you want to add on anything? Because the person, Mr. G. Kamaleshwari, is concerned about the high urea.
Okay. Is the creat also high, ma'am?
Yes, creatinine is 1.9, and there is it is not an acute kidney injury. That's what they have specified.
Okay. If it's not an acute kidney injury, then I would go with SIR. We go with the regular protein. If it is an acute kidney injury, then I lower the protein at that time. And when AKI settles, then I come up with the protein again.
What is the basis? Why do you want to restrict protein in this situation?
Because AKI is previously for AKI 2-3 years before, we used to have high protein as per the KDOKI guidelines, but now they also differ that protein should go lower when there is a kidney impact, go lower as 1 gram or 0.8, and then come up when creat starts settling down.
Very good. So it is also a guidelines based recommendation. So the next
Yes.
question from Aishwarya Nair, I think Dr. Manish has answered this. We have had a good discussion. A patient with recurrent ascites and multiple LVP, do we still need to adhere up to 5 grams of salt, or will it be cut down to 2 or 3? So as early answered that there is no need to strictly cut down salt if there is refractory ascites requiring repeated tapping, and if the patient is unable to tolerate the low salt diet, and because of that he is restricting his calories, we can liberalize the salt intake, Aishwarya. The next question is, in case of morbid obese patients, how to calculate protein requirement for patients with HE? Reshma, do you want to answer this question quickly? Morbid obese patient, how to calculate protein requirement for patients with hepatic encephalopathy?
Yeah. For patients who are obese, either you go for the actual body weight or you calculate the adjusted body weight. For HE, we are not going to restrict proteins, but obese patient has only 75% of the weight by muscle. So I would be giving only protein for that weight and not for his actual body weight.
So how do you calculate this ideal body weight in these obese patients?
So either you go with the IBW, that is the ideal body weight, height minus 100, or for the adjusted weight, what I would do is, for example, his actual weight is 140, I minus 140 with the ideal body weight, and for the muscle, I use 0.5 or 0.3 to 0.5 multiply, and then add that to the ideal body weight.
Okay.
So for 140 kgs, might be his ideal body weight would come around 90 or something. Adjusted body weight would come around 90.
Thank you, Reshma. So the answer for your question is that the protein requirement for any morbidly obese patient is done for his ideal body weight as calculated by Ms. Reshma. So there are calculators available. So there is no specific protein requirements for patients with HE. For all morbidly obese patients, we need to calculate for ideal body weight. So the next question is there any chance of rehab with help of nutrition to a cirrhosis patient who contracts other hospital diseases like pneumonia or TB, or maybe at risk of septic shock? And how to improve immunity of cirrhosis? So, Reshma, do you want to answer the first part of the question, that chance of rehab with help of nutrition to a cirrhosis patient who contracts other hospital diseases like pneumonia or TB?
Yes, ma'am. As we discussed a lot about prehab and rehab, so that guidelines appears the same appear for the patient also.
So even if they contract TB or pneumonia, we need to adequately replace the calories and proteins as per his requirement, and make sure that he takes it. Does not stop with the prescription. Make sure that he is achieving that level of calorie and proteins. And how to improve immunity of cirrhosis patient? Dr. Monish, you want to answer this question? Is there a way to improve immunity?
I don't think there is a way to improve immunity. And most of this data on immunonutrition improving, decreasing infectious complications also not, very strong, robust. It is, most of the studies which showed that benefit with immunonutrition has been, the sponsored studies or the industry studies. When the investigated studies, most of them have not shown any great benefit. So, and immunity probably is something which is, I know in the general population it's an abstract idea, but it's too complicated, and for a singular or even multiple interventions to actually improve it. So and
Okay, so thank you. So there is no way to improve immunity in a cirrhotic patient. There is a full conundrum of thing called as cirrhosis associated immune dysfunction that itself makes them more prone for infection, and that itself says that this patient needs early liver transplantation. So thank you, Dr. Monish. I'll go to the next question. How do immunosuppressive medications influence nutritional requirements and food choices? I don't think so that immunosuppressive medications specifically influence any nutritional requirements and food choices. It is for the patient as such and his dietary requirements only. And the next question is from Aishwarya Nair again. Patient diabetic since 10 years, CBG shows 306, but patient is severely sarcopenic. So can we neglect the CBG values and process with high calories, or should we take CBG as a concern here? Reshma, do you want to answer this question?
Sugars have to be controlled if we have to improve the nutrition of the patient. So we have a lot of methods to decrease on their sugars. So whether it could be fiber, or if he is too early satiated, use a soluble fiber to decrease on the sugars. So all the meal timings, what they're taking, or they're taking more of simple carbs. So sugar control is very important, especially if it's going for transplant also.
So, Aishwarya, what Reshma wants to tell is the mere CBG more than 306, we should not restrict calories. The patient needs whatever calorie he needs, whatever protein he needs. We need to control the sugar with the mode of carbohydrate what we give and the anti-diabetic medications. Especially in a cirrhotic patient, we usually tend to give insulin rather than oral hypoglycemic agents and monitor sugars adequately. So the crux is manage sugars, give adequate calories, change the carbohydrates what you eat. Don't restrict calories in this situation also. So I go to the next question. How long should we follow neutropenic diet for patient with liver transplant? Dr. Monish, do you want to answer? Is there anything neutropenic
I don't,
diet and do
I,
we
I don't
follow
know the
that?
answer. No, I don't know. I don't follow this. I don't know the answer to this.
Yeah, see, we are both from a big transplant institutes, and Reshma is also there. We don't follow anything called as neutropenic diet, and they are advised to eat everything what they want to eat, and it should be safe to eat, and it should not carry any infections. That is the basis. Okay. So I go to the next question. Are regular protein supplements like Ensure, which are heavy on maltodextrins, okay for prehab and cirrhosis? Reshma, do you want to answer?
Supplements, as you said, ensure wouldn't meet the patient's calorie as well as protein. You need a higher calorie and protein in lesser volume for the patient. So you have to check the calorie and protein of the supplement, whichever you are going to give for the patient, and whether the deficit is being met in that supplement.
Okay, so the next question by Zakira, I think I'm unable to understand. I'll just read it out. If anybody can understand, you can answer that. Most of the hepatic diagnosis, bile is also a problem where protein is not suggested. Abdominal distension and gases formation is also seen with acid reflux. I think I am unable to decipher anything. Anybody? I think I need to skip this question because it doesn't make any sense to me. So I'll go to the next question. How do we estimate calorie and protein requirements for a liver transplant patient with no ascites, good frailty index up to 5.0? Yet do we tell the patient is having sarcopenia? Frailty index of 5.0 is frail, I think. So I
It's
think they
bad
got
actually.
the point wrong. So I think we'll take the first half of the question. How do we estimate calorie and protein requirement for a liver transplant patient with no ascites and having sarcopenia? We'll answer this question. Reshma, do you want to answer this? No ascites, having sarcopenia.
So he's obese, ma'am.
They have not specified anything about that.
Yeah. So if he's not anyhow, patients with CLD also have 20% of malnutrition is there. If it's decompensated, they're 80% malnourished. So for this 20% also depends upon when we are assessing how much he's taking, and the rest we need to meet. Usually we go around 30 to 35 kilocals in the pre-op itself. And if he is not obese, 30 to 35 will do. If he is obese, I will go lesser on 25 and go higher on the protein, 1.5 or 2.
Okay, thank you, Reshma. So the next question is, how do you prescribe exercise for a bedridden patient with decompensated cirrhosis, severe ascites, marked fatigue to prevent sarcopenia and frailty in the patient? The mere point that he is bedridden without able to get up and do his course itself says that he is severely sarcopenic and frail. So in this situation, we can't prevent sarcopenia and frailty. But how do we prescribe activity or exercise in these patients and rehabilitate them is the question. Dr. Monish, do you want to answer this question?
difficult. I do agree. I think we can advise them. We can start with the basic stuff like spirometry, which they might do. And lying on the bed, they can do exercises using something called resistance bands or therabands. So
Exactly.
they might not be able to work their lower body or core, but at least some amount of movement, some amount of muscle strain would be beneficial. But yes, it's very difficult. These patients are, and I think, the most difficult ones.
Okay, that's good.
But then,
Okay.
it's a message for me that, okay, even transplant, they would carry not a very good outcome.
Exactly. That's what I wanted you to emphasize, that a patient who is bedridden because of frailty and sarcopenia will not have a good outcome, but we can try to prehabilitate them or rehabilitate them in this situation where we are not advocating transplant. If they get rehabilitated and become better, we may consider him for a transplant. And in these situations, what we have found helpful is nasogastric tube feeding, continuous feeding has helped some of our patients to get the adequate nutrition, because when they are bedridden and their eating habit will be less. And somebody has asked about pink salt. Salt is a salt. When you taste salt, whether it is black, white, pink, or yellow, it has the same amount of sodium. So it is the same, and replacing one salt with the other will not help reduce sodium level. And malnutrition and sarcopenia influence the prognosis of encephalopathy. How? I think we have explained everything in detail with pathophysiology and everything in our discussion itself. Do you want to give a quick recap, Dr. Manish?
I'm just kidding. I'm so sorry.
Mm.
Hello? Hello? Hello, Arison.
Okay, so I would like to answer this question, that malnutrition and sarcopenia influence the prognosis of encephalopathy. Yes, we said that after the liver, muscle are the sources where the ammonia gets, the urea cycle happens. So when there is sarcopenia, there is hyperammonemia, and it again causes hepatic encephalopathy. Okay, so how do we
Ma'am,
manage?
we will stop with the questions here. The balance
Yes,
questions
sir.
I sent
Thank you.
across
I
to
was
you.
waiting for you to
You,
intervene. People
yes,
are flooding with lots of questions.
yes, ma'am. Many of the things are coming as reputation. We will share
Yes,
the presentation to them, and
yes.
also we will provide them we will send back the questions to you. Maybe you can look at it and then
Thank you.
that's good.
Thank you.
Okay. Is it okay, Dr. Monish?
Yes.
Okay. Right.
Mm.
Welcome. Thank you. Thank you very much. As I was telling you earlier, I virtually traveled along with Mr. R almost for 8 weeks, and you have nicely explained many of the things, beautifully moderated, I would say that. Clearly, on malnutrition, sarcopenia, frailty, how the three are not the same thing you have discussed about. And very important, people, I'm sure, would have understood the barriers, how it can be addressed while feeding a cirrhotic patient. We have moved from a cirrhotic patient to hepatic encephalopathy, grade 3 and 4. And then also those challenges were primarily discussed by you. It was an excellent journey. Zinc supplementation, the clarification was very nicely given. Similarly for BCAA. And very important and nicely addressed was the late evening bedtime snack. What's the relevance in this regard? And I like this, madam. 2 grams of sodium per day different from 2 grams of salt. Very simple message, but definitely clarity. And 8 weeks of routine and exercise, how the patient has significantly is better compared to the patient who doesn't follow the nutritional regime as well as the exercise. So thanks a lot, Dr. Radhika. Really, you have set the right perspective overall for this particular panel discussion. And Dr. Monish, your tremendous insights definitely did help us in this regard to understand these challenges much better. And Reshma, as usual, that your experience hands-on, I think so. You have been virtually day in and day out dealing with so many challenges of this cirrhotic as well as for the liver transplant patient. I'm sure this would have helped a lot of attendees today in this particular regard. And I thank all of you for that enlightening discussion, whatever you have given us. And thanks for the audience in this regard. I also would like to thank my back office team. the Pulse Nutrition, who have really worked very hard. Twashika, Saurabh, and of course, finally, Mr. Kiran Das. I think you have put a lot of things together for this webinar to happen in the organized fashion. Thank you very much, everyone, and good night. Thank you.
Thank you. Thank you, Dr. Monish. Thank you, Reshma. Thank you, Ramesh and Dr. Kiran.
Thank you, Radhika, Dr. Radhika. Thank you, Ms. Reshma, and thank you, Dr. Munish. Thank you, Ramesh, for taking us through.
Wonderful session.
Really appreciate it. It was a wonderful session. We really enjoyed it. It was thoroughly enlightening. Thank you, everybody. Thank you, audience, for having been through the entire session. We had a very good audience and very interactive questions. Thank you so much.